Good afternoon to everybody. At the outset, I would like to thank Dr. Vijayakumar for having me given the opportunity to address the gathering here. Of course, as it was nicely elucidated by the previous speaker, and of course, the good introduction was made by our chairperson. So this is a very important part of the clinical situation where once a person subjects to you, as a type 2 diabetic patient visits you, the assessment and investigations should have been started much earlier than what is being now talked about. So many a times the people actually, they come to us very late, as rightly pointed out by the chairperson. There is a lot of hesitancy from the patient side, and of course the spouse also talks about it. And after that only the expression starts. So by the time the patient has crossed about 10 years of diabetic life or 5 years of diabetic life. I would like to just start with the introduction of a patient who visited me about 3 days back. The patient stopped medicine actually for about, say all the medication stopped. He said, he actually said, because of the medication, certainly I developed this problem, sir. So I got erectile dysfunction. I don't want to continue the medications. To this extent, a person thinks there's myths and misconceptions are too many in the practice, among the people, and they might even stop the medications because of that. So we got to it's a duty of the clinicians to actually deal with these people in a proper way, and before they start talking about bombastic investigations and trying to do something. So with this introduction, I will take you through the subject. Of course, you know about the incidence and prevalence of diabetes, about more than 425 million population available with diabetes in the world, and about 20 to 80% of the ED is there among the prevalence. Of course, in India, it's about 25 to 30%, but the details are not much more. And of course, as rightly pointed out the previous speaker, the diabetes is now occurring at a younger age group. So the problems are more in India. We are having as a nation, we are facing much more microvascular problems. And of course, it increases as increasing the age. And in younger males, it has got a greater increase in the risk of future cardiac events, which was well elucidated by the previous speaker. So needless to emphasize on this fact now, with this august audience, there is a very high risk of cardiovascular problems, though assessment and investigation should have been addressed along with that. So early onset ED is a much common problem in younger persons. So causes of ED is multifactorial, and so it starts from psychological factors, disorders. And because of the erectile dysfunction, they go for a lot of psychological impact, and the quality of life actually impacts. So when you're talking about the quality of life with the old age and anybody for that matter, when all the complications can lead on to the poor quality of life. And we have not really assessed the impact of erectile dysfunction on the quality of life in the years to come with the diabetic patients, and it's much more important. Of course, the vasculopathies are there, neurological disorders are there, which also accompany the diabetic patients. And of course, hyperglycemia per se can reduce the erection of the erectile dysfunction, it can aggravate the erectile dysfunction. Of course, needless to emphasize, the smoking is a very important factor, and drugs and alcohol abuse, and some of the drugs used in hypertension can also cause erectile dysfunction. Of course, this has been nicely elucidated by the previous speaker, the pathophysiology. I'm not going in detail. And of course, it's more of a endothelial damage which occurs in the place. So the clinical features to start with erectile dysfunction is usually very gradual and progressive. And many times you miss it, and many times people talk very late. And earliest feature is the inability to sustain erection long enough for satisfactory intercourse. And of course, there's the initial intermittent erectile failure, and it can be sudden onset. And that sudden onset usually due to psychogenic cause. So you've got to reassure a person once the person visits you, and that's more important. Loss of libido, consistent with hypogonadism, but not reliable symptom. Of course, men with ED often understand that sex is drive for a variety of reasons, and that has to be real. So the approach to patient is more important, and I would start prevention is more important than this. So it starts with the history taking, how we are going to deal with the person. So you got to listen to him properly, and not to, as rightly said, only 2 minutes time we have to dispose the patient, especially at the fact end of the discussion is going to talk about the erectile dysfunction. We have only 2 minutes to prescribe. That should not be the way. And probably you can start the moment a person starts stating about describing the complaints itself is a clear notion. He starts looking from the sides. If some attendant patient, one of our attendants sitting along with this, might be looking at the patients and even definitely will not reveal. So more privacy need to be given while you're addressing the patient. History has to be taken with more privacy, and confidentiality should be there, and intensity of the observation that is made by the physician is also very important. So you got to ask what type of physical activity he has. Of course, whether recent weight gain has happened, that is also one of the important contributing factors for erectile dysfunction. And smoking history, how many packs, how long he has been smoking. Of course, the diet taken, whether the person has low content of whole grain foods or legumes and vegetables and fruits, and a high intake of red meat and fatty products, and number of drinks of alcohol taken per week also matters a lot. Even the mild dose of alcohol may be aphrodisiac, but more the dosage, it can cause more damage, and the liver upsets the liver, and so hormone production is much less, testosterone production is going to be low, and in the long run, there is a problem with the erectile dysfunction. Of course, the most important is any treatment taken by ED, and many a times before the patient visits, they would have tried a lot of non-allopathic treatments available in the market, and with lots of myths and misconceptions, they would have entered your in a chamber, and all these need to be considered by the clinician. Of course, investigations, very common investigation we do, serum testosterone is considered, total testosterone is more important, and the prolactin luteinizing hormones and assessment of cardiovascular status as nicely elucidated by the previous speaker, and ECG, lipids, HbA1c, and sugar levels need to be maintained, because simple control of blood sugars in the initial days can really improve the erectile dysfunction. And of course, electrolytes and penile Doppler is a very important investigations. And serum PSA need to be checked with, because as you give the hormone therapy later on, it may aggravate the prostatic enlargement, and of course renal function test is very important, as we normally do with other people. So considering the historical investigation studies of the blood flow, we have been talking about a vascular problem with the penile texture. The penile brachial pressure index is a very important investigation, and plethysmography. Many of these we don't do in our practice, but the most important is history taking other things, and penile MRI is also there, and infrared spectrophotometry is there, and cavernous smooth muscle content also can be measured by the thing. Of course, the physical examination should not be ignored. Features of hypogonadism has to be checked before going and start treating the patient or doing a lot of investigations. And you got to really refer to whom the person should be referred. And of course, the protuberant abdomen, that could be one of the causes of the erectile dysfunction. And manual dexterity is very important. How dexterity, how mobile he is, how agile he is very important. And of course, the phimosis, all those things, testicular volume does matter. That has to be examined. And maybe the simple, the varicose veins, all those things are all important causes of erectile dysfunction, and because of the volume of this thing. So, and International Index of Erectile Function questionnaire is a very important tool and gives a lot of information. The tool is, but the score is between 5 to 25. And this got 5 segments. There are 5 stages. And say severe and moderate, mild to moderate, mild, and no ED. These are 5 stages. So 5 to 7 is 5 to 25 is a range of the score. In the score of 5 to 7 is almost is a very severe, and the last one is 25 to 23 to 25, 22 to 25 is no ED at all. So this is a range. So that tool is very validated tool. It can always, all of us can possess and have it, and it can be given to the patient, or it can even talk to them and get and we can identify the problem much earlier. Of course, in patients with type diabetes, reference for the ED, a diagnostic flow chart should include the total testosterone, and of course the PCDU, that's a penile echo Doppler ultrasound examination after intracavernous injection is also done. The points to note at this point of time is the TT score. The TT levels, total testosterone serum levels below cutoff of 264 nanograms is at least 2 different measurements to be done, and that's targets set by the Endocrine Society. And of course, the DM has listed among the conditions that lower either the sex hormone binding globulin or total testosterone below the normal range. In these cases, the clinician has to consider that a value of free testosterone, which is less than 64 picogram, confirms the presence of hypogonadism. So these are all small points that we can do and assess, and clinically we can suggest. Of course, various tests are being recommended, and the recommendations can be, the evidence can be B, C, D, and so on. And of course, many of them are done in the evaluation is done at a higher level. The vascular evaluation starts like combined intravascular injection stimulation CAS is the first line investigation. The duplex PCDU, I said, that has to be done. And of course, it gives a parameter of PSV, resistive index, cavernous artery system occlusion pressure, cavernous artery intima media thickness, and so on. And dynamic infusion cavernosometry and cavernosography is a third line investigation, evaluates the penile venous outflow system. The penile angiography, a third investigation for young patients with ED secondary to trauma. As I just seen the picture, this is one of the photos taken from the patient who had within a arteriography, where it's shown clearly the various arteries, and in the side there is a graph showing the flow pattern and the muscle erection and so on. So this is a picture taken after the graphy where we have seen so here you can see the extravasation of the this thing because of the trauma and because of fracture, penile fracture, and here you can see the venous filling happening. All these things are all tests done to show that the causes. Of course, you can draw graphs like this showing the various forms of erection, various phases of erections. Of course, the psychophysiological evaluation is the most important thing, and penile tumescence study and rigidity monitoring are to be done. Stamp test, which were done those days, and snap gauzes can be used. Regiscan is a very important investigation that has come up nicely, automated portable device which accurately predicts the veno-occlusive dysfunction. It's very easy to carry out, it can carry on. And NPT electro bioimpedance also is there. Audiovisual and vibrative stimulation can be done. Neuroimaging is there, and using PET and functional MRI along with the video or pharmacological stimulation. Many of these investigations are more of very high end, and once we refer the person to the particular specialist, they cannot do these things. But it's, as a clinician who are practicing diabetes, we got to concentrate more on these three other things. A neurological evaluation which can be done in our lab with biothermometry and bulbo-cavernous reflex latency. Autonomic nervous system examinations must. Can simple measurement of heart rate and postural hypotension, all these things are very, very vital, and that can be done. Hormone estimation is evaluation has done already, which I told. I'm not going to dwell into it. Of course, the PCDU examination, which clearly explains whether, despite lack of standardization of sampling location, it's done. The cutoff values, a major effort has been made over the decades to identify the PCDU waveforms predicting the arterial venous ejection erectile dysfunction. The PCDU allows the measurement of peak systolic velocity and end diastolic velocity of the cavernous arteries in response to ICA drug administration. So both of these parameters describe the characteristics of blood flow in the cavernous arteries during erection and are currently used for the diagnosis of vasculogenic ED. And of course, so this is the diagnostic and therapeutic algorithm that has been there. And of course, the therapeutic thing will be done by Dr. Anbuchelvan. And diagnostic, once the patients are subject to us, systematically investigate erectile dysfunction. Once you would say it's FCS evaluated, and the most important is if the person has gone into some cardiac problems, so sexual activity not advised. Here you cannot advise sexual activity at this point of time, and assess the cardiovascular once the person comes. So multidisciplinary neuropathic assessment has to be done in order to assess autonomic neuropathy. And of course, we have the hormone assessments, we can classify them with the total testosterone above 3.5, below 2.5, about 2.5 to 3.5. Then the testosterone therapies. For the therapeutic aspect, I think Dr. Anbuchelvan will do nicely. So coming to the take-home message is erectile dysfunction is the most underreported and clinical entity of diabetes mellitus. The younger the diabetic population, the more severe ED is going to be. And since it's a hallmark of vascular endothelial damage, evaluation for ED has to be done for all diabetic patients much earlier than what we are talking about. The newer modalities of investigation and therapy has revolutionized the care and approach towards erectile dysfunction, and it's treatable, and above all good glycemic control should be the slogan as far as clinicians are concerned. Thank you for the opportunity. Thank you. Algorithm that has been there, and of course, the therapeutic thing will be done by Dr. Anbuchelvan. And diagnostic, once the patients are subject to us, systematically investigate erectile dysfunction. Once you would say it's FCS evaluated, and the most important is if the person has gone into some cardiac problems, so sexual activity not advised. Here you cannot advise sexual activity at this point of time, and assess the cardiovascular once the person comes. So multidisciplinary neuropathic assessment has to be done in order to assess autonomic neuropathy. And of course, we have the hormone assessments, we can classify them with the total testosterone above 3.5, below 2.5, about 2.5 to 3.5. Then the testosterone therapies. For the therapeutic aspect, I think Dr. Anbuchelvan will do nicely. So coming to the take-home message is erectile dysfunction is the most underreported and clinical entity of diabetes mellitus. The younger the diabetic population, the more severe ED is going to be. And since it's a hallmark of vascular endothelial damage, evaluation for ED has to be done for all diabetic patients much earlier than what we are talking about. The newer modalities of investigation therapy has revolutionized the care and approach towards erectile dysfunction, and it's treatable, and above all good glycemic control should be the slogan as far as clinicians are concerned. Thank you for the opportunity. Thank you.